Thank you for having me here. I'm Mario. I'm the fellow with Dr. Jorgensen and Dr. Paparella at Minnesota. I'm gonna be presenting the capsule dehiscence syndrome. So the main reason I just select this topic is that basically I just saw back in residency a couple of the patients that actually have some dizziness, vertigo. And when I was doing the clinical, the evaluation, the clinical presentation was just so typical of superior semicircle canal dehiscence. And then when we obtained the imaging study, I just get frustrated because they were negative for superior semicircle canal. And then, I think that most likely we were just missing some of these diagnoses, and that's the main reason we were not able to actually do the correct diagnosis. So now I start to feel more familiar with this kind of dehiscence, and I'm more aware of it. I mean, it's something that I'm looking for in the scan. So I think it might be helpful in that sense. And also the other thing is, as we know, it's a fairly new diagnosis. So there's not a lot of information regarding the different treatment options. And I hope that with this discussion from the other sides, we can have another perspective or maybe some approaches regarding the treatments.
Hey, Mario, as far as background, do you want to just introduce where you did your residency and what your plans are for next year? Because I think that's interesting too for everyone to hear.
So basically, I'm from Puerto Rico. I was born and raised in the island. I completed my residency back at Puerto Rico, and I just went here to have like a 1-year fellowship of ear surgeries, have more experience. Our program is fairly familiar with Dr. Paparella's fellowship back in the days. We have 2 attendings that were trained, so we were fairly familiar with that kind of training program. So my whole idea was to came, here in Minnesota, get the training and get back to Puerto Rico. And if I'm able to be part of the university there, helping others being trained.
Yeah, and so Mario's, so he's got a job lined up at a hospital with also an affiliation with the university, 1 day a week working with the residents there in their otology program. So, great.
Okay, so basically we have a patient it's a 35-year-old female patient who come to the clinic for established care. She mentioned that she was diagnosed with left side Meniere's disease in 2006. And then basically she mentioned she had an extensive testing workup, including lung disease testings, MRI, vestibular testing. Basically, she had been treated for Meniere's disease with diazides, intratympanic steroid injections. She was also evaluated for vestibular migraine. She was diagnosed with vestibular migraine, multiple treatment options with anti-migraines medications without any kind of improvement. And she was really frustrated regarding all those, being evaluated by many other physicians without having any major improvement in her symptoms. She was basically complaining of constant tinnitus, described as a whooshing sound. She mentioned that she had a fairly sensitivity to loud sounds, and also like in places where there was a lot of background noises. He mentioned that it was like some kind of atalia, and also she felt a little bit dizzy. She didn't mention like gross vertigo, but she might just feel a little bit dizzy, and she also have like constant on daily basis like a chronic vertigo. She described like the dizziness as more like a boat, as being in a boat sensation. It was not necessarily like room spinning, as I was saying. And she also mentioned some hearing loss and some oral fullness. I'm just gonna point this the history, right? And I'm just going to go over the presentation, and then I'm just going to show you some of the CT scan results of this patient. Sure. So basically, just providing a little bit of background, which I think is important. In 1998, Miner described third window abnormalities, defects in the integrity of the bony structure of the inner ear. The first basically defect that was described was the superior semicircular canal dehiscence. That is now something that we're fairly familiar with the diagnosis, but it was just recently, right, in 1998, right? In 2005, he reported a review of 65 cases where he described that these patients were presenting with sound or pressure-induced vertigo, oscillopsia, and some chronic disequilibrium. He pointed out that basically 83% of the patients present with vestibular symptoms elicited with loud sounds, and 68% of the patients present some vestibular symptoms with pressure-induced, like sneezing, coughing, straining. And in 2008, Merchant and Rosowski proposed a universal theory about the mechanism, actually, of the hearing loss, which accompany these defects. So as we know, the main reason of this slide, just point out that it's something fairly new, right? And we are now getting more familiar with it, and we're getting more experience with it and more information regarding other Otic capsules, dehiscence. So as I say, obviously, it's like abnormality of the integrity of the bony structure of the inner ear. These patients might just present with sound and pressure-induced vertigo. So we know it's Tully phenomenon and Hannah-Bird sign. We have a low frequency air-bone gap, and also like a low frequency supernormal bone conduction in the hearing test, in the audiometry. They also may present with chronic disequilibrium, not necessarily like the typical vertigo room spinning. They might just present also with brain fog, autophony, hyperacusis, pulsatile tinnitus, and they might just also point out that sometimes they might just hear their eye movement, and also like loud steps of their own, right? As you can just remember from the previous presentation, some of the symptoms are overlapping with the typical vestibular migraines, and also like with other Meniere's symptoms, right? This is basically the typical audiogram of a third window syndrome. If you can take a look, we have like the air-bone gap in the low frequencies. Mostly, it can also go up to the mid frequencies. And then we have like the supernormal, usually of the bone conduction. It's really important that not always this is seen in the audiogram, and sometimes it can be a little bit tricky regarding getting the diagnosis, because you can have like your bone conduction in the normal level thresholds. And it can also vary depending on the type of dehiscence, right? Most of the information I'm just showing is based on the studies that of superior semicircular canal dehiscence, but now we're gathering more information regarding the other type of dehiscence. So third window physiology, if we think about it, what we think normally happen is that basically we have the motion of the stapes, right? And there's a difference in impedance between the scala vestibuli and the scala tympani. And basically that difference in impedance will just create like a difference and a motion of that fluid in the inner ear, which will just stimulate the cochlear partition and give you like the sound. The way we think it's just creating the air conduction loss is basically that having a third window, doesn't matter what type of third window, is just creating like a shunting of that energy towards the third window, and then stimulating less, right, the scala vestibuli and the scala tympani having less stimulation. So it's part of the energies just shunting through the third window. When we think about the supernormal bone conduction, the way it is explained is that basically we have a different in a normal ear, which is the image in the left at the top, a different impedance between the scala vestibuli and the scala tympani. So basically when we have like a bone stimulation, there's compression and there's a compression of that liquid inside the different part of the inner ear. And basically because of that difference in impedance, there will be like a movement of that liquid, which will result in a stimulation of the cochlear partition, right? So when we now know that having like a third window, it will just create a greater difference between the impedance between the scala vestibuli and the scala tympani. So every time we have that kind of a stimulation and energy and compression, it will be easier to go through and stimulate, like go all the way through the scala vestibuli, and as a result, giving a higher stimulation of the cochlear partition. So there's also the Tullio phenomenon and Hannah-Bird sign, and it's basically because now you have a path of less resistance. Part of that energy is going through the vestibular system, which is not supposed to go through, right? So when you apply loud noises or pressure, it will just create some of the movement inside the membranous labyrinth, which will create like movement at the ampulla, the superior semicircular canal, in the case of superior semicircular canal dehiscence. So it will just create like some nystagmus and also some stimulation. It can also happen with negative pressure, right? And it will just create the opposite, but it will just give you some vertigo also resulting from the stimulation of the superior semicircular canal. So how is the diagnosis, right? We already talked about the typical symptoms, right? And then once you have these patients and you have the suspicious for superior semicircular canal dehiscence, which is the one that is more, we're more familiar with, right? Obviously, we already discussed part of the audiogram. It's usually have a typical presentation, but as we point out in previous presentations, patients not necessarily only will have superior semicircular canal, right? They can have hearing loss, sensory narrow hearing loss, they can have veneers, they can have middle ear effusions. So there's a typical pattern we already discussed, but then we have to keep in mind that there's other things that can be present in this audiogram. I think that the most important thing is being familiar with the supernormal bone conduction in the lower frequencies, obviously knowing that there's a air bone gap in the low mid frequencies. And the main thing that you want to differentiate if this is something from the ossicular chain or it's something related to aortic capsule dehiscence. So that's why the stapedial acoustic reflex is so important, right? Because it will just be present in this kind of diseases versus otosclerosis, which we can think about when we see this pattern on the audiogram that will not show any reflex, at least when it's not in the beginning of the otosclerosis. Obviously, you want to have a tympanogram that is normal. It's not showing, right, any negative pressure, any flat timp that might just suggest middle ear effusion or anything else. The other thing and the most important thing is obviously the temporal bone CT scan, right? There's where we can just make the diagnosis. Here are different examples of Otic capsules, right? I will go over in different pictures about the ones that are presented here. But basically, you want to have a high resolution temporal bone CT scan. And it's really important. The other concept is like you can have Otic capsule dehiscence, but if you don't have the symptoms, you don't have Otic capsule dehiscence syndrome, right? So we are actually treating the patient itself. We're not treating the imaging studies, right? So that's really important. Other things that might be helpful are the BAMs. The CBAMs are really helpful. And basically, we now know that normal persons will have like a deflection on a curve elicit mostly 85 to 90 dBs when it's presented as a stimulus. But now we know that people with Otic capsule dehiscence syndrome might just have a lower threshold to elicit like the stimulus. We can see in this graph, this is from superior semicircular canal dehiscence. This person have like a stimulus almost at the 60 dBs and 50 dBs. We start to see some of the deflections on the curve. So that's something that can be really helpful. Also, it's not necessarily needed, but you can just order also. So what are the type of Otic capsule dehiscence, right? There's many, there have been many nowadays, like a lot of description regarding dehiscence. And the whole idea is just to be aware that there's many different, there's not only superior semicircular canal. And if we don't look for them, we're never gonna find them, right? This is obviously the superior semicircular canal dehiscence. We're more familiar. The arrows are pointing there that there's some dehiscence of bone in both sides. It not necessarily needs to be present in both ears. It can just be present in one ear. This is another example of superior semicircular canal dehiscence. We can see the dehiscence here, over here. And then this is also important, right? That dehiscence not necessarily need to go directly, right, to the middle fossa, you know, to the dura. It can also go to vascular structures like the superior petrosal sinus, which can cause some differences in the presentation of the patients. It's important to know that patients not necessarily will always present with the same like gamma symptoms. Some patients might just have more pulsatile tinnitus than others. Some people might just complain more of the auditory symptoms. Some people might just complain more of the vestibular symptoms. So it can just vary from one another. This is the CT scan of the patient that I was just mentioned at the beginning of the lecture, the presentation. And then we just can see that there's some missing in the superior semicircular canal. So in her case, now we have, you know, a finding that might just correlate with some of the symptoms that she was presenting, right? There's also another one which had been described more frequently now in literature, which is cochlear facial dehiscence. And this basically that there's a connection between the cochlea and the facial nerve. It's like a finding that is really subtle, right? If you're not looking for it, it's easier, you know, to get it missed.
Mario, this is the diagnosis of that patient I mentioned where we had done the full workup and we didn't see superior canal dehiscence, but another doctor later who they saw then got this diagnosis. And I'm not sure if they pointed out themselves or the radiologist did, but yeah, so we missed this one, but it's obviously pretty subtle.
Yeah. So here we have another example, right? It's something that if you're not looking for, you might just miss it, right? It's really difficult, you know. It's
for everybody involved, can you orient us and show us what exactly is what?
So basically, we have here the cochlea, some of the terms. This is the most the apex of it, And then over here is just the fallopian canal that is fused with that thorn. It's just we're missing like a septation of bone over here.
Can you point it out with your pointer? I see the two red spots. The red spots are showing.
Basically when there is supposed, I'm just pointing out, I don't know if you're able to see it or not.
Yeah,
It's
down in
just-
frame D delta, he's got his arrow where he's pointing.
Yeah. So basically when between those two arrows is where it's supposed to be the septation of the bone, like a bone layer separating in the facial nerve superiorly and the cochlea inferiorly.
If you're looking at this on your phone, your iPhone or your iPad, you can scroll in and look more closely. I'm guessing you can do it on your computer too. But.
Simon, you were able to see my arrow or not?
Yes, I see it now. Thank you. I wasn't sure what you were pointing to.
Okay. So this is another one, which is carotid cochlear dehiscence. And then it's basically a connection also between the carotid canal right over here. And then we have the cochlea over here. It's supposed to be a ledger over here. Where is my arrow pointing? But actually now we have like a connection directly between the two structures. I think it's easier to see in the right image. These patients also tends to present more with the pulsatile tinnitus than the other symptoms. Here there's the same carotid cochlear dehiscence, but now we have an actual cut, and then we have the cochlear turn over here, and then we have like the complete dehiscence of that septation of bone between the carotid canal and the cochlea. We can also have ampullary dehiscence, and it's basically that in this case, the end of the lateral semicircular canal is just basically have a loss of bone in there, bone layer in there, and it's just open to some air cells surrounding the Otic capsule. You can see it over here also. So some of these changes are really subtle. We can also have the dehiscence between the jugular vein and some of the inner ear structures like the vestibular aqueduct. We can see that in the left image, we can see it over here. This arrow obviously is just titled with the dehiscence. And here we have a dehiscence between the inferior jugular vein and the cochlear aqueduct. This is another patient that we have. We just evaluated. It was a similar history as the one that I presented before. So he's about, I think it was 55-year-old. And basically he was just complaining mostly of vertigo and oscillopsia. The vertigo was not that drastic, but he was saying that basically when he was in a really crowded place, he started to feel dizzy and he might just have some vertigo. This is a facial lateral semicircular canal dehiscence. So here we have the facial nerve, the fallopian canal. Then now, if you take a look, there is a dehiscence portion over here.
Yeah, I would never see that, and I'm not sure even a great neuroradiologist would catch that.
Mario, was this one that you found after? Because I remember after you prepared this and were ready to present it the first time, we found another case of this. Was this that second case?
This was the second case.
Hey Mario, this is Alex. I was looking at that image that you were showing, and it almost looks like the dehiscence goes into the fallopian canal, like it's like the facial nerve on top of the dehiscence. Is that just me, or?
Sorry?
It looks to me like the lateral semicircular canal dehiscence goes into the fallopian canal, like the facial nerve is right on top of that dehiscence.
Over here, you mean?
Yep, a little bit more inferior, or to where you, yeah, the
Here.
facial nerve, that looks, I mean, it almost looks like the facial nerve to me, and then adjacent
Exactly.
to it. And so
It's
like the
just-
facial nerve is covering the dehiscent area, correct?
Exactly. So there's a connection between the fallopian canal and the semicircular canal. So it's not like that the semicircular canal is exposed to like the mastoid. It's just like that layer of bone between the facial nerve and the lateral semicircular canal is just missing.
Did you think that that was attributing to his symptoms?
So that's the whole point of the presentation, right? It's difficult to actually state, right? Because this is so subtle changes. It's just based on imaging study is in a location that is really difficult to, access and just repair. And that's why I think the most important thing is to rule out anything else going on, right? If you see the series of these cases, most of those cases have been treated for almost 2 years, like even with the same doctor for vestibular migraines, for Meniere's disease. There are different treatment options. And I'm just pointing out, if you have that patient that is not responding as you were expecting, right, and persist with some symptoms, just look at it and try to find if this is something, right, that is actually might just causing some of the symptoms. And that's the whole idea of my lecture. I was pointing out to Dr. Jorgensen. I just want to know if you guys have some patients that you might just notice some dehiscence. If you think it's something that is actually causing the symptoms, how will you like to treat it, or how will you treat it? Yeah, because I think that the whole idea is like, you're just, rule out every diagnosis, and then this is a finding. Is this actually what's causing it? That's the question. I agree with you.
Mario, why don't we put it out there, like have a few comments on how they treat superior canal dehiscence, and also has anybody treated another form of dehiscence such as carotid?
It's later in the presentation. I talk a little bit about it. Like the
Oh, but
different.
do you want to, since we're on the topic right now, do you want to open it up?
Yeah, I mean, it's so for superior semicircular canal, which is more familiar, there's different like approaches, right? And it will depend, I think, mostly in the surgeon hands and how comfortable it feels, right? We know that the typical approaches are the transmastoid with the cranial plugging, also like the medial cranial fossa. Obviously, the other question is if every single superior semicircular canal dehiscence needs to be treated, right? And we have found that a lot of patients are just like, have a lot of anxiety regarding what's going on with them, right? And some have gone through a extensive workup. Nobody have actually explained to them, what's going on with them. So when you find the superior semicircular canal and just explain to them actually what's going on with them and the possible explanation, they might just tell you, doctor, I don't want any surgery. I feel okay. I can just avoid some of the, triggers, and it varies. But most of the time, like for superior semicircular canal, those are the main treatments. There had been other, propositions regarding round window reinforcement, with, different results. It depends from where you're reading, right? I think it's an option. I don't know if you're gonna resolve, but I think that the two main options for superior semicircular canal are either through the medial coronary fossa or transmastoid. I don't know if the other sides disagree or have something to add to that statement.
I have a lot to add, but in the time in your presentation, I don't want to interrupt. And we presented, actually, I surveyed all the neurotologists around the world and ended up with a paper based upon it. I did it with 2 medical students, and we published it in 2020 or 2021. Let's see, when was it published? In 2020, it was published, and we did a basis for standardizing superior semicircular canal dehiscence management. We presented it in New Orleans in 2019 because I find this diagnosis beyond frustrating. And for the most part, unless I find that 99% of these patients are like very complex, dizzy, tinnitus, migraine patients. And my standard story, I should probably let Mitch or Luke tell what my standard story is. I think I will. Do I get excited and operate on them, Luke, or do I tell them to run away from me as fast as I can?
You tell them to run away from you as fast as they can, unless loud sounds cause them to hit the ground like a narcoleptic cat. I think that's your go-to liner. Yeah, we tell people to run away as fast as we can. And I think before we would ever do a middle cranial fossa approach, we usually coach them and doing like a round window plugging, round window, oval window plugging, because it's less invasive and can work about 40% of the time.
So do you find clinically that the round window occlusion helps in a lot of your patients?
Who's talking now? I've heard your voice a couple.
I'm sorry?
Who's talking?
Sorry, this is Alex Tampio, Dr. Bax's fellow.
Hi.
I was just, hi again.
Yeah.
I was just,
yeah.
Sorry, after you.
I've had multiple conversations with both Lloyd Minor and John Carey. And John in particular says, I don't understand why a plugging of the round window would even help or work. And I said, well, because you go back from 3 windows to 2 windows theoretically. He goes, yeah, I don't get it. And I said, I don't get why you don't get it. And go back and forth with that. But so, I mean, if we really believe that it's the 3rd window that's causing the problem, and if you plug the round window and it's all connected, and it is, then theoretically it should help. And Herb Silverstein and Jack Cartouche groups were the first to try doing this. And the ballpark number that I tell people is it works 1 out of 4 times, so about 25%. And I say, look, that's right in the realm of placebo, and maybe you want to get better. I mean, I'm very honest with these patients, and I do chase them away. And then I tell them, don't go to my buddy Larry Lundy, who I'm close colleagues with and have a great deal of respect for, although he's now retired. I said, don't go to my buddy Larry Lundy because he'll do a transmastoid approach and usually doesn't work. So, and then I also say, don't go to UCLA because they'll do a middle fossa approach and they have a high likelihood of deafening you and making you a balance cripple. So, I find this to be a miserable diagnosis. The only reason I like finding is that I believe it explains some of their symptoms. Every single person surveyed in our paper except one, and I think probably everybody on the phone has seen it, where there are people that incidentally we found bilateral semicircular canal dehiscence and they have 0 complaints. So then that makes me question, are all these people's complaints oral fullness, low frequency hearing loss, high frequency hearing loss, conductive hearing loss, autophony, hearing your heartbeat, hearing your eyeballs move, hearing, your ankles clack, The original description by Lloyd Minor and John Carey was people dropping like a narcoleptic cat. And as he said, so that's my standard line I use with people. So the people I love to operate on are coming to me from New York and Chicago, and they say they walk down the street and somebody beeps the horn and they fall down and they pick themselves back up. And then somebody drops a tray on the street and they fall down. Those people are debilitated. We have, I always tell the story, I have an FBI agent whose only symptom is fullness and pressure in one ear, and it drives him bonkers, or her bonkers. And I said, I'm sorry, and they have this superior canal dehiscence. I don't know if that's the cause of the problem, but we did a plugging on this particular person, didn't make them any better. And he wants me to do a middle fossa, and I'm not real excited about it. He's got perfectly normal hearing and no other symptomatology other than severe oral fullness, only complaint and a big dehiscence. And the other issue, so the other thing that Larry Lundy has published, I think he's published on a couple hundred of these, is what we all used to do is we used to all resurface them, do a middle fossa, lay a piece of fascia down, put some, bone dust down and do roofing work, drywall work. That's all I explained to my patients. And then both John Kerry and Lloyd Minor said, no, it doesn't work. You must occlude the canal. Well, in occluding the canal, I can't tell you that I have a 25% or a 20% deafness rate, but that's the statistics around the world, is that 1 out of 5 people, when you plug that superior canal, will go deaf. And I'm sure that that's not all of our experience. It's not all of my experience either. But I just think, this is one of those things where the treatment is oftentimes worse than the disease itself. And be careful what you wish for. So I'd say get the hell out of my office politely, and don't go to my buddy Larry, and don't go to UCLA where they'll operate on you. And so we put together an entire program about how these people should be managed. Now, that being said, tomorrow, Luke can tell you we're doing 3 craniotomies, one for middle fossa approach for a superior canal dehiscence, and I'm dreading it. We're doing an SOC for something else, and we're doing another SOC for a CSF leak that I caused after removing a tumor. Perfect result, removing the tumor, but this guy's drained and I can't stop his leak. So we have 3 craniotomies and 3 other surgeries tomorrow. So we are doing a middle fossa tomorrow for superior canal dehiscence, aren't we, Luke?
Yes, we are.
Yeah. So
One thing I wanted to mention, when I explored doing the round window reinforcement as an option, and with based on Herb Silverstein's paper, he has a like a questionnaire in there for patients to self-assess their symptoms. And I found it's really hard for patients to subjectively say whether they're better or not after the surgery. And I think that questionnaire can be helpful in that to help show them, oh, see, you actually rated your symptoms as worse before the procedure. Does anybody else use that? Or Mario, maybe you're going to be talking about that later.
I have a fair amount to contribute as well, but Mario, why don't you go ahead with your presentation? I think that will have even more out there on the table.
Okay. So basically, this is what we were just discussing, right? The different things that can be done. Round window procedures, reinforcement, transmaster approaches, middle cranial fossa. Obviously, it will depend on how the severity of the symptoms that the patient is presenting and how debilitating are those, right? This is just to show like a video from the house group regarding the plugging of the round window. It's basically harvesting some cartilage and some perichondrium.
Mario, that title, that's a
yeah,
mistake.
I just make that
Okay.
mistake. I'm
Just
sorry.
making sure.
I'm gonna go fast on this ones so we can just go over. This is the questionnaire that Dr. Jurgensen was just pointed out. So basically they were just comparing the subjective respond to the treatment in patients with superior semicircular canal dehiscence and the round window reinforcement. This was the Silverstein group. Basically, they give you some question regarding the typical symptoms, and then you can just point out the severity of your symptoms. And basically what they found was that there was a subjective improvement in every single symptoms, just the hearing loss. It was not like any kind of benefit from it, but most of the others were just, helpful. This is another, this is from Rogers in New Jersey. Basically, they were doing the round window reinforcement for cochleofacial nerve dehiscence. And basically what they were pointed out is like the dizziness handicap index, there was a statistical improvement in the scores and also in the HIT6. And then they also measured the CBAM response, and there was some decrease in the improvement in the threshold of the CBAMs with this response. All of these are really low. You know, it was only about 16 patients, 8 in each group. So, you know, it's not like a study with a lot of power, but it's, you know, some of the first papers actually stating some improvement or responses to these kind of treatments. And they basically point out that one of the subjects that Dr. Seidman was just pointed out, they state that actually they cannot necessarily state what is the mechanism of improvement, right, of the third window. Because in the same way, if we think about the changes in impedance regarding the scala vestibuli versus the scala tympani, adding something to the round window will just, you know, basically create more difference. So not necessarily you're supposed to have a benefit regarding doing the round window reinforcement. This is the transmastoid approach. This is from the group of House.
This video.
This is basically, I just pointed out because sometimes, I mean, nowadays some of the centers are actually doing the
Superior
surgery
semicircular canal is
endoscopic
This
underwater.
depict
And basically, they're just exposing the membranous labyrinth. They just do the blocking at both ends of the superior semicircular canal. They just then cover the surgical part.
this video.
So this is a study from Glasgow, United Kingdom, regarding transmastoid canal plugging a superior semicircular canal. So basically, they find out that mostly all of the symptoms improve in their population in the study. The only thing that wasn't improving was actually the hearing itself. There was no difference, but the rest of the symptoms and the dizziness handicap index were just improving in the patients that they do the transmastoid. This is the medial cranial fossa approach.
Function.
This is not something that we're currently doing right on Minnesota. So I'm not that familiar with the procedure, but Dr. Seidman was explaining a little bit, but basically you do your craniotomy, you're exposed
Semicircular canal.
the superior semicircular canal, and it depends on what actually
We then
we're gonna
place
use.
our-
Some people plugging, resurface, or just add some bony pate or other material to just give support to the area. If you have any time,
with some
or
tissue
Dr.
overline.
Seidman, if you want to point out, because I always wonder what is the post-operative like care of these patients when you do it. And this is basically a study measuring the improvement in some of the symptoms regarding doing the medial canal fossa approach. Basically, it shows some similar outcomes regarding compared with the transmastoid approach. They obviously the hearing loss was not improvement, and in this case, our fullness, there was now a major statistical improvement, and the hearing loss. I think that the other ones was those two were the ones that were not statistically, in improvement doing this approach. And basically, this is a multi-institutional study that compare one with the other, and they basically found that there was no major difference between one and another. What I mean, it's in this subject, there's a lot of studies that basically compare one and another, and there's no like, you can find everything in that sense. Some papers point out that actually the medial cranial fossa has better outcomes, and some others that basically there's no difference. So I think it's, as Dr. Seaman also point out, it will depend on the center and the surgeon in some way. And then this paper was just recently, I just found it out this January, and they were just proposing like a classification for these third window abnormalities. It's from Lyon, France, and basically they give you an algorithm. Basically you have like the extra labyrinthine dehiscence. They just separated in type 1, which are the Otic capsule meningeal dehiscence. You have a type 1A, which is the superior semicircular canal dehiscence. And then you have a type 1B, which I didn't show any picture, but it's a posterior fossa, posterior semicircular canal dehiscence. And then you have the type 2, which is Otic capsule vascular dehiscence. You have the type 2A, which is basically the superior petrosal sinus, superior semicircular canal dehiscence. And then you have the type 2B, which is the jugular vein vestibular structures dehiscence. And you have the type 2C, which is the carotid artery cochlear dehiscence. And then there's the type 3, which is basically the capsule petrous bone structures of dehiscence, like facial nerve cochlea dehiscence. That's the type 3A. The type 3B is mastoid ampulla of superior semicircular canal dehiscence or lateral semicircular canal dehiscence. Type 3C, which is cochlea and IAC, that can also be seen a dehiscence. And then you have the interlabyrinthine. There's other type of third window or dehiscence. And then there's some patients who have multiples. And then you have some patients that have the clinical presentation, but you're not identifying on CT any kind of dehiscence. Basically, that's the presentations, and these are my references.
Well, thank you, Mario. I think I'd like to make a few comments. I agree with Michael's comments that these patients are easy to find and fun to find. And most patients are really benefit from knowing what it is that's actually causing their symptoms. But you have to be really careful about offering surgical repair and violating the fundamental equation and rule in medicine that you never want the treatment to be worse than the problem. So when I find these patients, I operate on about 1 out of 12 dehiscences I identify. And those patients have actual disability, not just annoyance from their symptoms. They have disability from them. Their life activities are disrupted. They can't do the things that they want to do, they need to do, say that they're going to do because of the severity of their symptoms. A lot of them have symptoms that perhaps wouldn't be very bothersome, except that they also have concurrent migraine. And when you treat the migraine, the symptom burden goes down so much that symptoms that seemed really bothersome and intolerable are then much more tolerable, and they have less headache. You could always argue that, oh, well, they wouldn't have migraine and that the dehiscence is the provocateur, it is the cause of the problem. But you have to be really careful when migraine is present. If you operate and you disturb the labyrinth and create a labyrinthine weakness, for example, they can sometimes, you can really provoke the central nervous system, and those patients can have very difficult postoperative courses and difficulty compensating. One of the things that I'm really interested in is this dehiscence between the tympanic segment of the facial nerve and the ampulla of the lateral canal. A series of these patients is being published, a small series, and there's a good case study that is included in it, in which a patient had very extremely low VEMP thresholds, the superior canal dehiscence, had a successful repair with elimination of superior canal function on head thrust testing, VHIT, but only a partial increase in the VEMP threshold. And the patient subsequently was found to have a dehiscence of the facial nerve at the tympanic segment and the ampulla. And the oval window was then filled with fat, and the patient had a complete resolution of their symptoms. The reason that this is really important is that a lot of patients may have more than one site of dehiscence, and that in general, patients with labyrinthine dehiscences have not only thin tegments, low tegments, but they also have thinner labyrinthine bone around their semicircular canals and perhaps around the otic, the entire otic capsule. So we have to be aware of the possibility of multiple sites and combined dehiscence in individuals. So that's something I think that's really worth paying attention to.
I had a question for the group. This is Alex Tampio. Let's say you're doing a middle fossa to repair a CSF leak, and there's a concomitant dehiscence of the semicircular canal. You can definitely see it when you're doing the middle fossa, but it wasn't causing them problems, and it's essentially asymptomatic. But you're doing a middle fossa anyway, and you're resurfacing the tegment defect. Do you occlude or try to resurface the semicircular canal at the same time if it's asymptomatic while you're already there, or do you hold off?
I hold off. You know, we fix a lot of these repairs. We do a lot of CSF leak and encephalocele repairs, and almost all of them have low tegments, multiple dehiscences of the tegment, and many have an asymptomatic concurrent superior canal dehiscence. Now, that's always the mystery. Why does one patient have, well, what is the factor that makes a dehiscence asymptomatic in one individual and crippling in another? And I know when we're resurfacing with cartilage and fascia in those patients for their encephalocele repairs that we are disturbing the surface of the superior canal, but I haven't ever had a case where the dehiscence became symptomatic afterward. So I do not make any effort to deliberately occlude the asymptomatic canal.
Yeah, I think you're looking for trouble. I certainly wouldn't occlude it. You could argue, I think your point is a valid one. If you came across a big dehiscence, you might cover it with some fascia and be very gentle and hope that you don't disturb anything. I don't know, Mitch, you should, Mitch and I think I'm involved in this one too. We were asked, Gerard Giannoli, Jerry, is writing a book, and we have one article on the pediatrics and superior canal dehiscence, and we have another article on geriatric patients. I don't know, Mitch, maybe you want to share what we found or what we're thinking about.
Yeah, so the chapter that I just wrote was on the geriatrics, and there were some things in there that I learned through literature review, not from personal experience necessarily, that I thought was kind of interesting. One is what happens with us with aging may or may not make us more symptomatic from a superior canal dehiscence, and specifically things like dural thickness. There's been some reports in the neurosurgical literature that show that the thickness of the dura follows a pretty fairly consistent regression over time. And so our dura gets thinner and thinner. And the thought is that maybe if you've had a bony dehiscence over time, but maybe you had a thicker dura, and so maybe you weren't transmitting the pulsations, or maybe you weren't as symptomatic from the dehiscence. But as that dura thins, now you might be able to appreciate the pulsatile nature of your tinnitus that maybe you weren't before. So I think that's one where I think about when you see, now that I'm looking at a dozen of these scans a week, and I see a dehiscence where they're asymptomatic, things like that sort of cross my mind. And maybe there's other factors in play, like maybe they're getting protection from a nice thickened dura. And then some of the other stuff that we found that it's worth mentioning is the effect of bone thinness and actually the bone morphology of the middle fossa. And so specifically, we've all looked at scans where someone has a widely pneumatized petrous apex and everything is wide open. And then we've seen other scans where it looks like it's fairly solid bone. And there's, for those interested, there's several publications on classification schemes of the temporal bone and of this area, and whether, the different bony types and how they think that with aging, just like we see osteopenia and osteoporosis in folks, that perhaps you're going to see thinning of a certain bone morphology, which might make one more prone to, Otic capsule dehiscence syndrome as they get older. And so there's some interesting facts about that that is out there. And then one of the other things that I wanted to sort of ask the group about that came up in the chapter that I'm writing is this concept of, all right, so now you have an older person who has thin dura, and maybe they are getting symptomatic from superior canal dehiscence, and they want something done, but maybe they're a little older, a little more frail, and say you're not super excited about doing a middle fossa approach. Could it be easier just to lift a tympanomeatal flap and to do a round window reinforcement and oval window reinforcement to try to take away that? Is that sort of maybe first line therapy in someone that's not a great surgical candidate or someone that's older, and then maybe save the more invasive, whether transmastoid, canal plugging or middle fossa approach? I was just curious if anyone's done that before, where they sort of stage those two procedures with that thought in mind.
That's how, when I started doing the reinforcement, I've only done a few. I offered both options to the patients, but the way I offered it was, this is less invasive. And when you offer it that way, I think most patients will take the bait on the less invasive one. If you say, well, this is less invasive, but it's not really going to help you, this is more likely to help, they might take the bait on the canal plugging or the resurfacing. But it's tricky because there's variable results, and it's hard to give patients hope when you really don't know. So I would say, based on what everyone said, if someone is really having a disability and they're elderly, I would definitely do a less invasive procedure to help them first. So
I think something to the fellows to learn from what you just said, Josh, is really important. So I think my experience is about 1 in 4 going to help, and it's within the realm of placebo. And many of us were taught in medical school that placebo is a dirty word. It is not. Used properly, there's a placebo effect, right? So I have been accused over the years. I mean, I'm considered an expert in herbal therapies, and I've lectured around the world on the topic. You can treat most medical disorders with an alternative, and there are at least 18 studies looking at ginkgo biloba, and not all ginkgo is created the same. It doesn't have the same amount of 6% terpenes and 24% ginkgo flavonoids they have to have. I mean, so not all of it is created equal. But 11 of the 18 articles that are randomized, some placebo-controlled, some not, show that there is efficacy. So there are two ways to say that, ginkgo will help or not help with tinnitus. You can say herbs are a bunch of BS, and this probably won't help and you're wasting your money. But if you're stupid enough to want to try it, give it a try and let me know after 3 or 4 months, if it works, great. If it doesn't, then you've wasted your money. Or you can say, hey, there are 11 out of 18 studies show an effect, 7 out of 18 show no effect. It's helped some people. And, maybe I would say if it were me, I would give it a try. But that's up to you. And I think it could possibly help. So if you couch the round window plugging, the less invasive thing, saying, the studies are all over the map, but some people will say 1 out of 4, 1 out of 3 chance that it's going to help. It's better than what you're suffering with now. And look, it's a very simple procedure, and the likelihood of me hurting you is so low. I think it's a plausible and reasonable approach. And we're here to care and love our patients and take the best possible care of them. We're not here to do anything dishonest or nefarious. And maybe it'll help, maybe it won't. And if it doesn't, and they're really debilitated, you can move on to something else. And at least in your mind, know that you've tried something.
That's excellent. And one other thought I had after the discussion was, with chronic sinusitis, for example, we're expected to treat medically before we treat surgically. And we just talked about how the fact that you have dehiscence in many patients who are asymptomatic. So why are they symptomatic? What else could be going on? And as Dr. Teixeira pointed out, if someone is prone to migraine, they may be more hypersensitive in general to any symptoms. And if you have cochlear hydrops on top of a dehiscence, maybe you're more susceptible. So should we be treating them for migraine and or Meniere's disease medically before offering these surgical options? Just a thought. What do you guys think?
Well, I always do treat them medically if I can. And a lot of times people are just so reassured knowing what the symptoms are coming from that they aren't really then looking for any problem. I tell them that, well, your symptoms could stay stable for decades or they could progress. I had one patient who had a slow history of progression of symptoms over 22 years before they finally started getting a Tullio, and that's when they finally went for repair. And but it's all started with ear fullness after a traumatic descent in an airplane, and they no one couldn't respond to tubes or any other treatment for eustachian tube dysfunction or for hydrops or anything like that. And finally, it was when the Tullio happened that it became clear what the problem was happening. And that was actually only in 2000, just shortly after Lloyd Miner's initial paper was published.
So I have a pretty interesting case that I'm taking care of. For those who don't know, I'm in the Navy. I'm a Navy ENT doctor down in Virginia. And I had a patient come to me recently who works on maintenance for the F-18 fighter jets. And he said, I thought it was so weird. Every time a jet was coming in for landing, I was the first to know because I started to get dizzy. And so we did a further workup, and turns out he has pretty classic symptoms, both Tullio phenomenon, Henneberg's phenomenon of superior canal dehiscence, and his skin is, shows a dehiscence. And I'm in the process of getting vent testing to kind of solidify things. And I'm talking to him about his options, because here's a young, healthy, active duty male who is very symptomatic and really has a professional reason why he should have surgery. And so I think we're sort of headed in that direction, but just thought it was kind of interesting. Not everybody is exposed to F-18s and gets both the pressure and the sound changes that could induce symptoms. And he's one of those folks.
Yeah, I've had two automobile mechanics, and it was the air hammers that every time they were working on something and someone was using one of those air drills to take tires on and off, that the whole world would tilt in one direction. And one of them actually had a nickname in the garage. He was called the Magician. If people couldn't figure out what was wrong with an engine, he would hold a screwdriver and put it on different parts of the engine, and he would be able to hear the site of wear, and he would say, it's the timing chain. The tensioner on the timing chain went out. And people say, you better be right, because this is like a week-long repair pulling this engine out. And but he was always right. And I told him, we can fix you now that you have this Tulio, but you will lose your superpower. And he chose not to be repaired.
Yeah, I was gonna say, man, I'd keep that
Great.
superpower. I think.
That is a great story. I think you need to write that one up. I in Mitch's last email where he said hope to see everybody, I sent people a copy of the paper that we did with the medical students. Again, it's nothing earth-shattering, but in the very first lines it says almost everybody to the question asked treats these patients medically first, with some vestibular rehab, with some avoidance therapy. If loud sounds drive you nuts, avoid those loud sounds if you can. So, I think it's very critical. And then there is some discussion out there, and I'm not the expert on this, and Luke's probably much more expert at this than I am, as Mitch, and as are most of you on this call, is that there's a lot of people who think that this, this could be a migraine thing, and if you treat it from a migraine perspective, some of these patients will get better too. And so I think it behooves us to try everything we can medically first before jumping to anything that's going to be permanent.
Do you guys order? I'm sorry. I was going to ask, do you guys order ECOGs also as part of the workup?
I have generally not been ordering ECOG. I depend mostly on the CVEMP and OVEMP, along with the CT, but mainly it's a clinical diagnosis.
So one question I had for everyone is, before you take someone to the operating room, do you always do CVEMP and OVEMPs?
I always do.
Okay.
Yeah, I think it's very compelling, especially if a patient has residual symptoms. You want to be able to see afterward if they have residual symptoms, if their V-hit changes, and if their VEMP threshold has normalized. And
After that presentation, do you all think that we could also use like a dizziness handicap index or another questionnaire as before and after to help know how, assess how well the patient responded?
Sure, I think it's a very good basic index of disability and validated. So I think it's valuable information to collect.
Dr. Teixeira, would you, if you had someone who had all the clinical signs, Tulio, Henneberg, CT scan, but they had a normal CVEM, would you still take them to the OR?
That's a good question. I'm not sure that I've had that. Sometimes people will have a normal CVEMP, but it's been misinterpreted because they have a conductive hearing loss. And if they have a normal CVEMP and they have any kind of conductive hearing loss, then they actually have a very low CVEMP threshold. So that would be so that's something that I think most people aren't very careful about when they interpret and report, CVEMP thresholds.
Right.
So if the patient has a conductive hearing loss more than 15 dB and they have a VEMP at all, they have a low threshold.
Oh, yeah.
So I have a question for Mario on this. Since you studied the physiology of all this, so of all the dehiscence syndromes that you looked at, is there one that may be less likely to have an abnormal CVEMP based on the physiology? For example, a cochlear dehiscence?
So it varies, to be honest with you, because basically in the reports, some of the reports show some of the VEMPs and other not, and there was like a was variable between some of the patients and other not. So I think that the CVEM is really helpful, but as Dr. was just mentioning, having a negative CBAM, not necessarily, I mean, you can have it and still having a non positive CBAM result. So I think it's the most important thing is like the clinical presentation and the whole things, all the vestibular testing are helpful. I know that a lot of people are currently doing the ECOG. That was one of the reasons I was just asking, and some people are doing the ECOG, even in surgery, to have some response after doing the plugging or the resurfacing to see if they have like a change in it and they feel more comfortable, like actually they were able to address some response already in the OR. But I guess that all of these are tools, right, that they're not definitive. So I will not rely only on one thing, at least I think.
I mean, certainly the patients who are most likely to benefit from surgery are the patients most severely affected. They have a Tullio phenomena, and if they have upward and out, if they have eye movements that are visible with the Barony noisemaker or with audiometry, we keep a portable audiometer in the exam room that is consistent with activation of that canal, then that is quite unequivocal, regardless of the rest of the workup.
Mm-hmm.
I think one form of dehiscence that wasn't mentioned that bears mentioning is diffuse dehiscence. You can have a decreased mineralization of the otic capsule that is not an actual opening, but it allows a large sound leak, and so you can see sometimes incomplete very disappointing airbone gap closure in patients who have really dramatic cochlear otosclerosis, far advanced otosclerosis, when you feel like you've done a very good standard repair. And it's nice to tell people ahead of time that they may have and not have the same kind of complete closure that you usually expect. One of the things that can happen is that if you have a patient who has otosclerosis, absent reflexes, and a superior canal dehiscence, which is asymptomatic, you always worry that, well, you do a stapedectomy on them, you improve sound access to the ear, and now you make an asymptomatic dehiscence symptomatic. And I have yet to have a patient who has become symptomatic after a stapedectomy. But I did have a patient who had a dehiscence, who had absent reflexes. We did a stapedectomy, and the airbone gap did not improve very much because they now had an airbone gap because of the third window. So they lost their Carhart notch, but their low frequency gap remained. Just
to add to the diffuse, I read that some of the patients with Paget disease also behave with a diffuse Otic capsule dehiscence.
Yeah, yeah. Another, back on the topic of the dehiscence at the lateral ampulla, that group of patients, according to Jerry Giannoli, seems to have a unique symptom presentation. A lot of them have a rocking sensation, which is really interesting. He thinks it's because it's proximate to the utricle, and not only do those patients have, it's interesting that they have a rocking sensation, because we usually think of rocking as a purely central phenomena, something that can't really happen in the labyrinth. And those patients, when they're operated at surgery, they uniformly have dehiscence of the facial nerve at the oval fossa. So that you could have a patient who has a dehiscence between the fallopian canal and the lateral ampulla, but if they're not also dehiscent at the oval fossa, that they may be asymptomatic. I have a question for people about how they do round window reinforcement. Do you drill the overhang? Do you try to strip mucosa off of the round window membrane? Do you use fat? Do you use cartilage? Do you attempt to truly stiffen the round window? And if you do you get a conductive hearing loss afterward?
I know Dr. Seidman will, what we do is we roughen up the mucosal lining around the round window and both the round window and the oval window with like a round window rasp or a rosin, and then use tragal perichondrium and cut it up in tiny pieces and just pack it in the round window and then around the oval window as well.
Mm-hmm. So no conductive hearing loss from it?
I haven't seen it, but I don't know if I guess I can't speak for Dr. Seidman if he's seen it afterward.
Never. And I worked with the older people on this phone may know Shiro Fujita, who brought uvulopalato-pharyngoplasty to the country years ago. So he was a pretty famous guy, well-known guy, terrific guy. He believed that everybody who was dizzy had a perilymphatic fistula. So I have fixed about 250 to 270 perilymphatic fistulas that I'm pretty convinced were not perilymphatic fistulas. I would never, ever say he was a charlatan or a huckster, but he truly believed these patients had these problems. They came from all over the place. And we did oval window, round window plugging. I mean, really just smacking the heck out of them not smacking, packing the heck out of them. And none ever had a conductive hearing loss, and I've never seen one from it.
I believe the paper where Silverstein described the technique, he used cartilage, not just perichondrium, and then the cartilage was to fit the round window. I tried doing that. It's really, really hard to do. I ended up putting cartilage and perichondrium, just plugging as much as I could and then reinforcing it with gel foam. But once again, the patient wasn't convinced how much they had an improvement after that, even though we did the questionnaire and we showed, well, you did actually report improved symptoms, but they weren't satisfied. So I like the idea of reinforcing both windows. It's a good idea, and roughing up the mucosa.
One group of superior canal dehiscence patients who have been particularly satisfying are those patients who have present with pulsatile tinnitus and a dehiscence at the superior petrosal sinus. And in those patients, I have just followed Satelli's angle down along the superior petrosal sinus right to the anterior canal, and then compressed the superior petrosal sinus and inserted perichondrium into the into the channel where the dehiscence is present. And it's blind, but you have this dural confluence that holds the perichondrium firmly over the dehiscence, and those patients have done terrifically well with resolution of symptoms, and certainly complete resolution of their pulsatile tinnitus and an easy post-operative course. But those patients were not plugged, just simply tamponaded at the superior petrosal. So SCAR is your friend, just like preparing a CSF leak.
Are there any other questions or topics people want to discuss before we hang it up for the night? Mario, really appreciate your talk. It was excellent. And like I said, I think this wasn't meant to be mini grand rounds for the fellows, but it was really meant to kind of spark discussion like this one did. So thank you very much. I think it was very helpful for me, and I think probably for most other people too.
Yeah, excellent discussion. Congratulations, Mario. Thanks, and always, Mitch. Thanks for taking the lead on organizing this. This is great, and I just wish we could get more people from all the sites.
So, guys, April 20 looks like the third Wednesday of next month. I'll send out a little reminder. If you know you can't make it in advance, we can obviously shift so that we maximize participation, but looks like April 20th. Alex, are you still on the call? I'm not sure if you can hear me, but I'll touch base with Alex. He had presented, I think, about half of the cases that he had prepared in the fall. So I might ask if he'll do the next one. And we can have a good discussion with the rest of his cases for the next one in April. But I'll send that out. And I know the fellows, most of you guys are probably on your final stretch here. And, good luck with the rest of fellowship and everything. Thanks all for logging on.
Thank you.
Here, good
Thanks,
night.
guys.
everyone.
Thank you so much.
Have a good night.
Thank you, Mario. Good night.
Thank you.